Well, thank you so much, Camilla. And how the dickens do I follow that? That was just so inspirational. And I mean, it was just so astonishing. I don't know about you, but I was thinking of some of the patients that I dealt with when I was working in hospital, who I thought was unconscious, and just trying to, I mean, it's a long time ago, but trying to think, what did I say? Anyway, I'm really delighted to be asked to give this keynote. I've been a member of the RCGP for 40 years now, and becoming and being a GP has been the absolute centrality, the essence and core of my career. Though I have to say it is a bit disconcerting now, when normally when I give conference presentations, I see all those years, all those hundreds of thousands of consultations being summed up in 3 words. It just says, David Haslam, a former GP. Be warned, that's what happens to your careers. 3 words. Now, but it's really good to be home now. When I've been a GP for only 4 years, the RCGP launched an initiative called What Sort of Doctor? This was a form of voluntary assessment, a system of performance review carried out by GPs in their own practices. It was based on 4 areas of performance: professional values, accessibility, clinical competence, and communication skills. But in essence, those of us who got involved just spent time going to each other's practices, producing a report, feeding back. There was no money involved. It was a really positive initiative. We learned from each other. We saw what was good. We saw what was less good. But I think it remains a question worth asking. What sort of doctor are you? What sort of doctor do you want to be? And if those answers aren't the same, what are you going to do about it? And there's another, I think, really important question. What sort of doctor do you want? Yes, your patients too. Indeed, I'd put it stronger than that. I think doctors are a deprived group when it comes to healthcare. I'll never forget getting a letter from my own general practitioner many years ago. It said, "Dear David, I've been reading about the problems of stress and ill health in doctors, and I've decided to write to all the doctors registered with me to invite you in for a health check." Indeed, he had identified that doctors tend to be a genuine at-risk group when it comes to their own health. So I went along for a checkup and had my immunizations boosted and blood pressure sorted and so on. And I then invited all the doctors registered with me. It wasn't many, but for them to come in, and most of them did. And it was a really worthwhile exercise, which I commend to you. And of course, I really do hope you are registered with a GP you can talk honestly and frankly to. That usually doesn't mean someone who you spend the day working with. And when choosing a GP, you need to know what sort of doctor you want. So what really matters? Now, there's all sorts of definitions of a good doctor. One I'm using here comes from Sir Donald Irvin, who was a former president of the GMC and honorary secretary of the college. And he said then, evidence is abundant. The public want doctors who are technically competent, give them the best possible clinical outcome, are as safe as possible, are kind, courteous, and respectful, and involve them in decisions about their care. I think now I'd change that final phrase to, and is prepared to work with them as partners. So how do you go about achieving this? Well, with apologies to all the great minds and great people who have written so brilliantly about the consultation in the past, and one of the joys of being involved with the college is to have really good friends like people like David Pendleton and Peter Tate and the ultimate guru of consulting, Roger Neighbor. With respect to all of them, my consultation model is quite a lot simpler. In full, it goes like this: shut up, listen, care, and know something. I could actually, if I thought about it, reduce it to a mere 3 bullet points, because shut up and listen are virtually the same. After all, you can't listen when you're talking, but listening, really listening, determining what your patient is concerned about, as Kate said, is becoming increasingly important in healthcare. After all, in a world of shared decision-making, of finding out what matters to your patient, of patient-reported outcome measures, of patients really mattering, of complexity and multimorbidity, then listening becomes more important than it's ever been. And you all know the research that shows doctors typically interrupt the flow of their patients' stories after an extraordinarily short length of time. how just shutting up for 2 minutes will typically allow the story to unfold, and how time invested at the start of a consultation will save time at the end. So I'm not going to go through all that again, but I do want to talk about caring and about knowing something. I mean, caring sounds awfully soft and cuddly, something from the world of psychobabble. But I think it's critical. If you care about someone who's consulting you, then you're automatically interested. All those tools, all those checklists of behaviors for use in the consultation, like introduce yourself or make eye contact and so on, you're going to do those automatically if you're interested in the human being in front of you, seeing them as a real person, someone who matters. So if we're interested in the person in front of us, if we care and if we show that we care, then so much else will follow automatically. And I absolutely understand the challenge of continuing to care and being able to demonstrate this when exhaustion overwhelms you. But I do think caring really matters, and I think it's fundamentally linked to trust. Trust really matters. Indeed, we're still an astonishingly highly trusted profession. GPs typically come top of all surveys asking, can you trust this or that professional to tell the truth? And our level of trust is despite everything that the media, some newspapers in particular, choose to throw at us. There's always a real risk that if trust is damaged, if you damage the trust, you risk damaging the fabric that I think holds the whole system together. And when we find ourselves in situations where we feel pressured to act in a way that we know is not really in our patient's best interest, it tears us apart. I've long been a fan of a quotation from Mahatma Gandhi. Happiness is when what you think, what you say, and what you do are in harmony. Is it any wonder that so many doctors are unhappy? They know what they'd like to do for their patients, but may not be in a position to deliver. And part of the problem, I think, lies with the fact that the core aim of what we try to do, which is fundamentally to help people get better, can get lost as we're faced with all sorts of potential distracting incentives. And this has a real potential to do tremendous damage to morale. And good morale is a very precious thing, which is why, for me, the secret of an interesting career is to mix with enthusiasts, which is what you're doing today. And I think it's a really important part of any general practitioner's career. And what about knowing something? Well, the simple fact is that as a generalist doctor, you have to know an impossible amount of information. After all, we care for most of the problems of most of the population most of the time. And then, as well as knowing it, you have to keep up to date. Pretty well impossible task. When I was a member of the Postgraduate Medical Education and Training Board, one of our tasks was to look at and approve the curriculum of each and every medical and surgical specialty. I've had a fun life. I don't need to tell you which specialty had the curious combination of by far the largest curriculum and by far the shortest training. Being a GP is an extraordinarily complex task. And then when you add in the business side, as well as an expectation that we'll run the NHS, whilst faced with a workforce crisis and increasing public and political expectation, well, all I can say is it's a good job that GPs are exceptional people. And when it comes to the extraordinary challenge of keeping up to date, I remember some years ago reading a research paper from Scandinavia that showed that if you were really, really motivated, and as a generalist, every night of the year read 2 new relevant research papers, at the end of a year, you would be just 500 years behind in your reading. Throughout my career as a GP, I don't recall a single surgery when I didn't have to make a note to look something up, or I felt that my education was woefully lacking. And it would have been bad enough if we were trying to cope with a body of knowledge that stays constant. Well, chance would be a fine thing. I mean, everything changes all the time. New evidence comes along, new guidelines, new forms, new expectations. It's quite a task. I mean, a while ago, I was listening to a radio program. It was a phone-in, I think, about dietary guidelines or something like that. And a caller said, and I love this, a caller said, "Why can't the scientists make their minds up?" And whilst I absolutely understand that frustration, it is confusing being told that fat is bad and then fat is good or whatever the latest controversy is, but that's the nature of science. Science isn't a question of just finding the answer and settling on it for all time, and it's finding the answer and testing it and checking it and retesting it, and changing your mind is central and critical to the scientific process. I mean, after all, when I was a junior hospital doctor all those years ago, we treated patients with a myocardial infarction with 3 weeks bed rest. 3 weeks bed rest, which included having to use a bedpan. Now, the ones that survived were immensely grateful. And I still have letters from them and their families thanking me for the fantastic care they received. But gratitude and recovery, whilst very welcome, aren't evidence. Quite simply, we were doing the wrong thing, and science ultimately proved it. And I absolutely understand that change can be difficult, especially when new evidence calls into question standard practice and we have to rethink something we've thought we've known for years. And I completely understand that sense of, well, what do we believe this week when it comes to hypertension or asthma or whatever? But the simple fact is that science will keep changing its mind. Indeed, that's the glory of science. Constantly checking, questioning, turning hypotheses upside down, refining the evidence, avoiding the risk that we'll just go on making the same mistakes with ever-increasing confidence. All this change is a good thing, but it doesn't half make life difficult at times. Wouldn't life be a lot more straightforward if we could just make our minds up? Well, ain't gonna happen, ever. So wouldn't it be fantastically helpful if there was an organization that did the reading and synthesized it for you? You've been waiting for that, haven't you? Well, this is where NICE comes in. If NICE didn't exist, either you would have to read all the research and synthesize it, or you'd have to find somebody else to do it for you. So my aim is for NICE to be seen as a resource, a genuine resource for GPs and for everyone who works in primary care. And over the past 3 years, I've listened to all the criticisms that we don't understand general practice or are dominated by specialists or over-focus on single conditions or fail to take notice of the impact of what we say on workload, or we live in an ivory tower, or never in the real world or whatever. So I thought it was worth just explaining very briefly how NICE develops its guidelines, though I'll go into this in more detail. I'm just literally going to dash through them now. There's a session in here at noon on multimorbidity where I'll go through this in a bit more detail. But the key values that we apply in all our work is to look at the evidence, bring in experts, but in everything we do, bring in patients and carers. Absolutely critical. Our committees are independent. We're independent of government, and the committees are independent of us. Genuine consultation, which means if we get something wrong, we will change our minds. I get irritated when the press call that a U-turn. No, it's part of the process. Regular review to try and keep things up to date. An open and transparent process. Our board meetings are held in public. Most of the meetings are held in public. Indeed, in our public board meetings, the chief executive and I take an hour's questions from members of the public who come on anything and everything. Being a GP is just amazing training for that, I'll tell you. And we have a lot, and also we take on board the importance of social values and equity considerations. And we do involve GPs a great deal in our work. Many of our expert committees include GP members. We're really keen to recruit GPs when we're looking at topics that affect general practice. As such, recently we've had GPs on our sepsis, non-alcoholic fatty liver disease, and our recently published multimorbidity guideline development committees. We've got 2 GPs sitting on each of the technology appraisal committees. We're about to start recruiting committee members to develop a new guideline on managing common infections. We've already recruited a GP to chair this committee, and we'd be really keen to involve more GPs in developing this important guidance. And the RCGP is, of course, a really important stakeholder, feeding back to us about our clinical guideline program and contributing comments on most of our primary care-related information. So let me reiterate, we are really keen to involve GPs in our work. And as a practicing GP, you can apply to join a NICE committee, comment on our guidance, or even apply to join the Fellows and Scholars scheme. There are few better ways to rekindle enthusiasm or achieve your CPD. And we absolutely get and understand the challenge of multimorbidity. How could we not? After all, there are more people in the UK with 2 or more long-term conditions than there are with 1 long-term condition. It's single long-term conditions that are the unusual. And later this morning, Bruce Guthrie and I will be presenting a session and a Twitter chat on NICE's guidelines on the assessment and management of multimorbidity. And for me, one of the really key questions about multimorbidity is the whole question of what good looks like. If you are someone with, let's say, coronary artery disease and hypertension and hyperlipidemia and diabetes and chronic kidney disease and macular degeneration and osteoarthritis and hardly surprisingly depression, and everyone here probably knows that patient, or at least someone with 7 of those 8 conditions, what does good look like? Because it certainly doesn't look like taking 8 guidelines and adding them together. That's almost certainly a recipe for overtreatment and polypharmacy. The only person who can really say what good looks like is, of course, the patient. And so NICE has become increasingly involved in discussing the vital importance of shared decision-making, something that should be meat and drink to every GP. And I've been particularly struck by the work of Al Mully and colleagues at the King's Fund, which show very clearly that not taking patient preferences into account leads to overtreatment and the very opposite of the patient-centered care that is our mantra. An international Cochrane review in 2011 showed that demand declined by about 20% after patients became better informed. The review reported consistent evidence that as patients became better informed, they made different decisions, felt more confident. Now, these are astonishing figures. If they related to the use of a new drug or technology, we'd leap on it. And as Al Mully has said, doctors, and I've certainly been guilty of this, frequently leap to our own conclusions about what a patient's preferences for care would be, but the evidence shows we're actually not very good at it. Al Mully calls this preference misdiagnosis, and I think it's extraordinarily important. And whilst patient engagement in that way is critical, disengagement can take many other forms. How about all those patients who, when you ask them what tablets they're on, they say, well, I've no idea really, there are the white ones and the other ones. And how about the vast number of tablets that remain untaken? Every GP tells tales of carrier bags coming back to the surgery after a patient's death, packed with drugs. Were these tablets that were prescribed after a full discussion of the benefits, risks, alternatives? Was the doctor really sure the patient wanted them? I know that shared decision-making takes time, and I know that time is the one thing GPs particularly don't have. Yet the opposite almost certainly involves overtreatment, waste, polypharmacy, drug interactions, and the rest. And dealing with that takes time, time that no one has to spare. So where does so much of this overtreatment come from? Well, I'm sure part of the answer, quite straightforwardly, is inappropriate application of guidelines. What do I mean? Well, part of my job involves me meeting the presidents of all the medical Royal Colleges on a regular basis, and one thing I hear from all of them is real concern that doctors, juniors in particular, treat guidelines as a cookbook, following every recommendation to the letter. And as I've said over and over again over the last 3 years, there's a clue in the word guidelines. NICE clinical guidelines, unlike our drug appraisals, are not mandatory. Our recommendations are based on the best evidence of what works, but healthcare professionals must use their clinical judgment as they apply guidelines to individual patients. A colleague of mine has a 90-year-old relative with severe dementia, so severe that she can't recognize any family member, was recently admitted to hospital having fractured her hip and had a stroke, one probably causing the other. And whilst in hospital, this patient was started on a statin. And when challenged, the doctor said, but that's what the guidelines say. No, what the guidelines say is, I quote, when exercising their judgment, professionals are expected to take the guidelines fully into account alongside the individual needs, preferences, and values of their patients and service users. The application of the recommendations in the guideline is not mandatory, and the guideline does not override the responsibility of healthcare professionals to make decisions appropriate to the circumstances of the individual patient in consultation with the patient and or their carer or guardian. And yet I think all too many clinicians skip past this bit of the NICE guideline like it's the terms and conditions on a website in search of the important bit to them, the drug dose or whatever. That's the important bit. That's the critical bit. Our approach, my approach to guidelines is absolutely clear. Patient values must be taken into account. When using our guidelines, doctors must satisfy themselves they're applicable to that patient. And as I've explained, guidelines use the best possible methodology available to bring all the evidence together. So I think the point needs making that if you're going to be at all evidence-based, which I think you should be, you're not going to find anything that does it better than the NICE guideline. And my personal view is that the future of medicine has to be much more focused around real individual patients, combining the best of evidence-based medicine and the best of patient-centeredness. Medicine should be something we do with patients, not to patients. And as such, we've been developing decision aids. I know they could be a lot simpler, but we've produced them around the use of statins, around anticoagulants in atrial fibrillation. We're trying to make as much of our guidance much more readily usable for GPs. It seems to me that GPs need information in two ways: short, rapidly accessible information for use in the heat of the consultation, and more detailed information for use after the consultation in learning about a topic in more depth. So to try and help this, we've published 330 clinical knowledge summaries, which provide GPs with short, accessible summaries of the current evidence base and practical guidance. We're trying to produce more and more of our information on apps. You can download the NICE Guidance app. If you come along to the NICE stand in the exhibition center, you can get more information there. And as for workload, well, it may not seem like it, but in drawing up our recommendations, we're careful to assess the impact of the recommendations on workload. And it's true that time and again, our guidelines, quite rightly, identify GPs as needing to do this or do that or whatever. But fundamentally, let's not forget what guidelines are there to set out, to describe the best and most cost-effective care for patients. So let's use that evidence and of the vital importance of general practitioners as a cast-iron argument for ensuring our profession is properly resourced to do its job. It's this kind of focus that will really improve the lot of our patients. And I'll certainly do everything I can to support real GPs doing an incredibly difficult job in the real world, because these are really interesting and challenging times. During my career as a GP, I lost count of how many political and organizational upheavals there were that impacted on general practice. The simple fact is, my patients didn't notice. They kept on coming with their dis-ease and their disease. They were worried and they were frightened and they were puzzled. And in the privacy of the consulting room, in that extraordinary intimate exchange between doctor and patient, they shared their fears and their hopes, and they told me of their errant spouses and their sickly children and their dying mothers and their dementing fathers. And they told me of the joyous births and the remarkable recoveries and the false alarms, and they shared their stories and the extraordinary complexity of the average human life. That's what GPs do. Whatever happens in the headlines, in Westminster, in the corridors of power, that'll continue to be what you do. And we have to remember that. It's easy and incredibly understandable to feel that at times the role of GPs is threatened, but our patients will keep on coming and keep us anchored in the real world. We will develop new partnerships with other professionals such as pharmacists, but there'll be more than enough work for all of us. The role of the GP, I believe, has never been more important. And when I look back at my diaries and remember some of the patients who came to see me right at the start of my career, I can see how little has really changed when it comes to what really mattered. And the good news is what really matters is probably what attracted you and I to this profession in the first place. So it's sometimes worth remembering that, and it's what our patients want. And the RCGP's crest, which is still used on membership and fellowship certificates, I think symbolizes quite beautifully what sort of doctor our patients want us to be. Sure, they want us to have high levels of knowledge. They want us to be competent, to know stuff, to be able to diagnose their rashes. Does anyone know what that rash on the lion is supposed to be? They want us to be their advocates in times of trouble. They want us to be guided by research and study as we straddle the twin religions of art and science. But most of all, they want us to care. Caring is a difficult concept to measure, and we all know that in general we measure what we can see and not necessarily the things that matters. But it's not for nothing that the college crest is the motto is Cum Scientia Caritas. We must never forget that one of the lessons of history is that while the scientific truths do keep changing, the human truths are almost certainly eternal. Thank you very much.